Welcome back. This is chapter 14, Organizing Patient Care. This chapter focuses on how patient care is organized within healthcare facilities. The primary means of organizing nursing care for patient care delivery include total patient care, functional nursing, team nursing, primary nursing, modular and model RN line, and case management. Models of care are developed to support or enhance professional practice, and by considering characteristics such as accountability needs to be considered when nursing practice models are assessed. Which model will be more effective? The goal is to keep the cost down, use staff more effectively while providing quality care. You also have to keep in mind that there is no one best model for organizing patient care, but we have many models to choose from. Total patient care. This is the oldest mode of organizing patient care. In this model, nurses assume total responsibility for meeting the needs of all assigned patients during their time on duty. The greatest disadvantage occurs when the nurses are inadequately prepared or inexperienced to provide total patient care. Even though we might say that students provide total patient care, they may lack skills and expertise for total patient care. This is not used much in today's organization, although some may use it in a modified manner. The greatest disadvantage of total patient care delivery occurs when the nurse is inadequately prepared to provide total care to the patient. Functional nursing. This evolved as a result of World War II. This method uses relatively unskilled workers who have been trained to complete certain tasks. Care is assigned by task rather than by patient. Emphasis on getting the work done through tasks. Care is assigned by task. For example, like medication is. The advantages of this method is it is efficient, tasks are completed quickly and with little confusion regarding who is responsible for what. Disadvantages: this may lead to fragmented care and the possibility of overlooking patient priority needs. In other words, staff become dissatisfied or bored. There is no growth. It is like a conveyor belt. This model can be used very well in long-term facilities. If you ever been to a long-term facility, you may notice that they have a medication nurse, they may have a wound care nurse, they may have an assessment nurse, and so on. Team nursing. Ancillary personnel collaborate in providing care to a group of patients under the direction of a professional nurse. This requires extensive team communication and regular team planning conferences. A team consists of an RN, LVNs or LPNs, and CNAs. This group provides all the care mainly focused on tasks instead of patient as a whole. Modular nursing. Modular nursing is like team nursing, but the team is smaller. It consists of 2 to 3 members. This is a modification of team and primary nursing. Like team nursing, but uses a smaller team, pairs professional nurse with ancillary staff to deliver care to groups of patients. Used frequently during the 1980s and 1990s. Primary care nursing. Primary care nursing was originated in the late 70s and it does provide challenging work. As originally designed, it requires an all-RN nursing staff. RN primary nurse assumes 24-hour responsibility for planning the care of one or more patients from the start of treatment to discharge. During work hours, the primary nurse provides direct care to those patients. The associate RN fills in when the primary is off duty but must follow the plan of care as directed by the primary. Hospital management thought that this was very expensive, but it's never proved. Case management. Case management is defined by the Case Management Society of America as a collaborative process that assesses, plans, implements, coordinates, monitors, and evaluates options and services to meet an individual's health needs through communication and available resources to promote quality and cost-effective outcomes. It coordinates care throughout an episode of illness, and the focus is on individual clients, not population of clients. One of the goals for case management is to contain healthcare costs. Clinical outcomes should happen within a prescribed time frame. Case manager is generally assigned a unit and can handle a lot of 25 patients. Case managers handle each case individually, identifying the most cost-effective providers, treatments, and care setting for the patient. Six core functions of case management includes assessment, planning, implementation, coordination, monitoring, and evaluation. Basic premise behind case management. Historically, the focus was on the individual patient. The medical world now revolves around managed care and diabetes instead of patients. Patients' role has shifted to that of customers. The MCAs want customers to be satisfied and they want to save money. So MCAs hire case managers to keep customers happy and to save money. So case manager focuses on disease management, plans for care for populations with same chronic illnesses. This slide includes the goals of case management. The premise of inpatient case management is that hospitals are better off managing the demand for care than attempting to try to increase the supply of resources such as beds or personnel, including nurses. Case managers do this by using critical pathways and multidisciplinary action plans to plan patient care. Care map. The care map is a combination of critical pathway and a nursing care plan. Combination of critical pathway and a nursing care plan that indicates when nursing interventions should occur. Commonly used in case management nursing to facilitate expected outcomes and to document variances. Variances and variance tracking. A variance is anything that occurs to alter the client's progress through the normal critical path. Benson et al. State that the true utility of clinical pathways is derived from information obtained through variance tracking, documenting when and why a patient's care varies from the clinical pathway that was normally supposed to be carried out. New ways of looking at how to provide healthcare is population-based. Healthcare population is typically defined in terms of covered lives. The goal is to service the optimal number of covered lives required to reach operational and economic efficiency. For greatest return on investment, the goal must be to achieve the best health possible for each client. Along with the population-based healthcare, now you also have disease management approach to care. Disease management approach can be defined as a comprehensive, integrated approach to the care and reimbursement of high-cost chronic illnesses. The goal of disease management is to address the illness or condition with maximum efficiency, regardless of treatment settings or typical reimbursement patterns. Thus, a continuum of chronic illness care is established that includes early detection and early intervention. In these programs, common high cost, high resource utilization diseases are identified and population groups are targeted for implementation. These programs include comprehensive tracking of patient outcomes, covered lives, that is, population of patients versus individual patients. This slide lists some of the chronic illnesses often managed with disease management protocols. Common elements of disease management programs include formulary modifications, educational interventions, outcomes assessment, modeling treatment options, and unique treatment options. These are some other features of disease management programs. It includes the use of a multidisciplinary healthcare team, including specialists in the area, the selection of large population of groups to reduce adverse selection, the use of standardized clinical guidelines, clinical pathways reflecting best practice, research to guide provider practice, the use of integrated data management systems to track patient progress across care settings and allow continuous and ongoing improvement of treatment algorithms. Differentiated nursing practice refers to an attempt to separate nursing practice roles based on education or experience or some combination of both. This is pretty new and has not been studied enough to know the outcome. The philosophy behind differentiated nursing practice is that registered nurses should work within the role structure and responsibilities that correspond best with their individual capabilities. Differentiated practice. It recognizes that education, clinical expertise, experience, and willingness to assume a more advanced role are what set registered nurses apart. Philosophy behind differentiated practice focuses on the division of labor needed to meet client needs and to provide distinct level of practice. In other words, it matches patient needs with nursing competencies. Development of clinical nurse leader. The American Association of Colleges of Nursing has initiated a national effort to create a new nursing role that is more responsive to the realities of the modern healthcare system. Clinical nurse leader is an experienced nurse, may have a graduate degree, clinical leadership in all healthcare settings, does outcome-based practice, quality improvement strategies, clinical practice, creates and manages microsystems, responsive healthcare needs of individuals and families. Choosing the most appropriate organizational model to deliver patient care for each unit or organization depends on the skill and expertise of the staff, the availability of registered professional nurses, the economic resources of the organization, the acuity of the patients, and the complexity of the tasks to be completed. In order to do this, you need to have enough RNs to do primary or advanced practice nurses for case management. Many nursing departments have a history of organizing patient care based on the current and most popular method instead of looking at which one works best for their organization or department based on the philosophy, employees, and goals. Delivery systems. Elements of the various designs present in the system in use in any organization facilitate meeting the goals of the organization. It should be cost effective, satisfy the patient, provide role satisfaction to nurses, allow implementation of the nursing process, and provide for adequate communication among healthcare providers. Cycle time reduction. Cycle time reduction involves reviewing an existing process that provides a product or service, determining where there's wasted time or effort, and developing an improved, streamlined way to achieve the same results more efficiently. This requires frequent reviews and revisions. When changing the patient care delivery mode, there are certain questions the change agent must ask. Those are: how will the reorganization alter autonomy and individual and group decision making? How will social interactions and interpersonal relationships change? Will employees view their unit of work differently? Will the change require a wider or more restricted range of skills and abilities on the part of the caregiver? Will the redesign change how employees receive feedback on their performance, either for self-evaluation or by others? Will communication patterns change? When considering a work redesign, these are the items to keep in mind. They are social interactions, degree of autonomy, abilities and skills, employee evaluation, and communication patterns. This completes chapter 14. Please let me know if you have any questions. Thanks.